we've had already a speaker. We've already gotten our teams and our judges lined up. I just want to say a couple of quick things. Thank you so much to our sponsors, Point Care, Informatics, to the EMIC team, to ACEP for having us, host this again this year, the third time. I know there have been struggles. I know there have been late nights. I know there have been crazy email chains before coming in ACEP. I just wanted to say it's been incredible to watch teams innovate, incredible to see people continuously come here. And I just can't wait for these pitches. I can't wait for the judging to happen, for the questions that come forward. And I can't wait, regardless of who wins and who doesn't, I can't wait to see what you do with your ideas in the coming year as well. So congratulations to coming to ACEP, to making it this far into pitching, and good luck. All right.
And we're ready to roll. So we will get started with our first pitch. Again, you'll have 10 minutes to pitch, and then 5 minutes for question and answer. I'll pass around the mic briefly so we can have the judges introduce themselves, and then we'll be off to the races.
Hi, good morning. I'm Leon Edelman, emergency physician and co-founder of IV Connections.
I'm Scott Simmons. As well as a co-founder.
Yeah, Kevin Spencer, I'm a mechanical engineer and ER doc as well, and co-founder of Free Rescue.
Josh Grasshopper, UK Innovation and Intellect Health Activity. Also clinically an emergency physician, had about 37 fire launches now.
Awesome. So no pressure, anyone, but we have some incredible experience up here. And really, this is meant to be a learning experience. We want you to get comfortable presenting ideas, getting feedback. That's what this is all about. It's about learning. It's about growing. And I hope from the bottom of my heart, this has been a learning and growing experience for you. So without further ado, I will pass it over to our first presentation for the day.
Good morning. I'm Kim Tranquata. I'm an emergency physician. And first, I want to thank ACEP. I want to thank EMIC. I want to thank International ACEP. I have felt so welcomed and supported, and it's great to connect our idea and our mission with our community. And I thank you. I also want to thank EMIC for turning the most overstimulating ADHD experience ever into something even more high stakes. Entrepreneurship is really about being uncomfortable, a physician entrepreneur in the entrepreneur space, a physician entrepreneur in a space that is very much dominated by tech personalities. And HACT has said, hey, why don't you just try and do something new in 3 days and make it even more interesting? And you know what I said? Great, let's do it, because that's how you get better. So thank you for this experience. I'm Kim Tranquata. Scott Lowry is one of my partners and collaborators with an incredible scheduled program that's permitting us to do some of our work. So first, I'm going to start with the problem. 78% of the world's trained physicians are currently treating 16% of the global population. It's that group up in the light blue, while 84% of the global population only has 22% of the trained physicians to provide care. And of course, the physicians that they train, for many reasons, economic reasons, tend to migrate back up to those regions where they're treating the 16% of the global population. Why should we care? Because disease burden is higher, of course, where there is less care. Lack of health care impacts us all globally. Things like multi-drug resistant TB, things like COVID-19, pandemics and epidemics. Poor health limits economic growth and opportunities. So overall, the whole world is poorer, not just economically, but in terms of innovation and things that people can contribute. And lack of healthcare contributes to lack of trust in government, which is one of the drivers of global conflict, which does affect all of us as well. So where's the opportunity here? There's an incredible opportunity to address global health inequity in one generation. Now, lots of people are actually trying to address global health inequity by more training, lots of programs. You'll meet lots of folks here that are doing that, but that is a long-term project that's going to take decades, and what's going to happen for those that are waiting for healthcare today and languishing without healthcare. There's also a projected 10 to 15 million healthcare workforce shortage for 2030, and most of that burden is again falling in the low and middle income countries. 4 million of that are physician shortages alone. We now have better platforms for telehealth. We have greater patient acceptance and greater physician acceptance of this. So our grand idea is to take the 13 million physicians we currently have trained globally and say, could you give us only 2 hours of your time? Impact we can make 700 physician hours every day available anywhere in the globe. Now we're focusing on the global south, the 84%, and we can have a massive impact. There's no travel, no expense, no coding, no billing. Physicians want to do this work, but for the traditional model, required a lot of time, a lot of travel, a lot of expense, really only open to a limited number of people to go do international telehealth. Now we can do it through telehealth in real time, right from your home with a simple 2-hour time slot. We have the platform, simple EMR and SoapNote with a partner, and we partner with other NGOs to also expand to other specialties. We've done projects in the Philippines, 6 clinics. We've seen over 1,000 patients. We have a project coming up in Kenya and Uganda, which is why we're here, where we will connect 2 rural hospitals, 5 rural clinics, and 2 boarding schools to each other, first through the telehealth platform, and then offer our services as another layer on top of that, and then offer specialty evaluations within 24 hours on top of that. We also have a project in Eastern Cape that we're working with the medical school to now bring their trainees into the rural areas where they have trouble staffing clinics. And when I say bring, I mean virtually bring by telehealth. The problem we want to solve for today is the follow-up, is the post-telehealth visit follow-up issue. So our patients may not be coming back to the clinic. They may be very far away. Will they have phone and cellular service? Thankfully, even in the poorest area of the world, most people have some version of phone and cellular service now. So that is a smaller problem, but it's something we do want to address. Who does the follow-up? When you have one nurse working in this rural clinic, will they have the time and motivation to do this follow-up? And is it sufficient to say the patient didn't come back, so they did okay? So what do we want to measure first, and how can we measure it? We want to make sure that we can report real outcomes, because this is a repeatable intervention that we want to do in multiple countries. So we want to address the UN Sustainable Development Goals. These are the 7 goals we want to address, and this is how we can measure them. Things like collecting demographics is good. That's easy, but asking specific questions, like are we using antimicrobials effectively, and asking specific questions around that. How are we integrating local partners and healthcare system collaborations? Are we getting more patients into the clinic, referring more patients to the referral center? So are we strengthening the local healthcare infrastructure? We want to, of course, measure the patient experience, because remember, we are a foreign NGO coming into another location, and we want to make sure that our intervention is culturally appropriate and competent. So did we advance their medical care? Of course. Are we getting repeat visits for the same problem? Is it advancing or getting better? We'd like to do video and phone calls to the patients at 48 hours, 1 week, and 2 weeks. Ask specific questions. For patients without a phone, we may need to have a community healthcare worker do this. So we need very specific questions, so a non-clinician can go in and get the same answers to the same questions, and then we have reportable data. And then link that to the EMR, so the provider that did see them can see the results of their follow-up. Local provider experience, of course, is also important. We have to make sure we are doing culturally competent care. So was the consultation helpful? Did it happen quickly enough? Was the platform easy to use? Did it support you in taking care of your patient? And was the consultant that you worked with respectful, professional, knowledgeable, collaborative? So a simple standardized questionnaire is what we think would work. Not only would this give us follow-up, but this gives us consistent data across multiple projects that we can then use to understand our outcomes, make improvements in our program, and report to people like people that are giving us grants, governmental bodies, etc. Follow-up can be done by any team member who's available because it will be standardized, so it doesn't have to be the provider that provided the care. Link it to the EMR so that the follow-up can easily be tracked. Perhaps have video and or photographs that you can transmit for things that you're not sure if the patient is improving, and have that on a continuously updated sort of Power BI dashboard that's driving data on a continuous basis, that's helping you make sure your operations are efficient and effective. Monthly reports to local collaborators and annual reports to international collaborators. And I am finished. I love questions, and that's how you can contact us.
Wonderful, thank you so much. So we'll now open it up to 5 minutes of Q&A from the judges. I'm gonna pass this mic down to you.
That was an excellent presentation, and more importantly, an inspiring presentation. I think that most of us are
Thank you.
We're mostly vaguely aware that there's a problem in the global south with lack of physicians, lack of healthcare providers, and it's causing problems. My question for you is, if we're going to ask physicians to do 2 hours of something to help the care, say in Philippines, Kenya, and Uganda, is it better to directly provide telehealth care to patients, or would that time be better used training up the staff that's on the ground?
Yeah, so the model that we're working with in Kenya and Uganda. So my first answer is in innovation, you try and then you pivot. So in the Philippines, we did sort of a hybrid where there were in-person clinicians and we augmented them with our online team so that we've made the healthcare workforce be able to see more patients. In Kenya and Uganda, we are providing consultation to the nurse or the primary care physician, the licensed independent clinician, so that we are integrating with the local healthcare system and helping improve their skills while expanding them. So we will learn from these experiences and come up with perhaps one model, but perhaps different models, right? It'll depend on the healthcare system and what they need from us. But the object is to not put more burden on the already short local healthcare system, but to help augment what they can do with our abundance. I know most of you don't feel like you're abundant, like you feel like you're drowning in ED. But if you look at the stats, we have more global abundance if we can share that expertise a little bit. Did I answer your question?
All right, I had a couple of questions. One related to that, about our shortage actually for healthcare workers here. Be considered using other advanced practice providers, physician assistants, nurse practitioners to help increase your workforce. How is that viewed from these other healthcare systems? And what is your funding model? I don't think I caught that. Do you have a funding model? Like, how is there a way to support this initiative?
Yeah, well, first I'm going to ask if you can fund us, please do. My current funding model is I'm a female emergency physician, and because of that, I've always worked 3 or 4 jobs. Not only do I send my kids to college, but I fund my company. But Look, the long-term funding model is sponsorships of programs. We are currently crowdfunding the most expensive resource, which is our expertise. So that is the most expensive resource. There is not a lot of infrastructure that we need to create. And we've also used the power of collaboration to get other companies like VC, like Global Telehealth Network, to work with us pro bono. So we're only 2 years old. So that's the start. Long-term, with real outcomes that are reproducible, we want to contract with the local ministries of health and say, this is what we can provide within your healthcare system. We can offer you different suites of services. We can either come in and help you set up telehealth and you use it yourself. We can come in and offer you telehealth with our consultations and then offer appropriate fees for the services based on that.
Yeah, thank you so much for the presentation. I'm just looking at from the perspective of like scalability, profitability, that lens on it. So if I understand correctly, right now this initiative is primarily directed towards elevating the healthcare provided to these regions because of the need. This isn't so much perfect. Yeah. So this isn't necessarily driven by like a return on investment goal right now. This is let's help people around the world goal right now. Is that correct?
That is correct.
Yeah. And so just as an idea or thought that came to mind, potentially even rotating this call through residency and medical school programs. I'm sure you've probably thought of this.
100%.
Where it's like you have access to supervised resources that are likely enthusiastic and involved.
Absolutely.
And there's a win-win on both sides. You integrate this with residency medical school programs across the world, really. And then that becomes a platform where the infrastructure that's built becomes potentially valuable in the future. Kind of like, I guess, as a loose analog, Uber figured out how to do this everywhere. Now everybody knows Uber, and there's all kinds of places that can go next. So Uber's not really a good example, but I think I get the idea here. So yeah.
I love where you're going with that. That's actually what's happening in Eastern Cape, South Africa. They approached us from their research institute and said, we'd love for you to come and help us use telehealth to connect our medical school to these rural areas. We have a really hard time staffing these rural clinics, but we have all these trainees that can't necessarily go to the clinic, but they can definitely provide telehealth to the clinic. So I also think this is I'm an old doctor, but this is the future for the next generation. And I would love to see residents and medical students doing this from their first day of medical education. It changes our lens about what healthcare is. We're become an interconnected global community, and we all have a global lens so that we're not surprised by these disparities, and we're working together internationally.
Yeah, very inspiring, so I really appreciated it. So 2 questions. One is more tactical, and one is probably, I would just encourage you to think about something in a certain sense. So the more tactical one is when we've done things along these lines, even actually using VC as our platform. One of the things that we found is that because there's an onboarding process, the 2-hour commitment for the physician, it's 2 hours plus the amount of time that they need to do the onboarding, and then they only do it for a couple hours, and then they do it for us, the following month, and then you have to actually re-onboard them on how to use the EHR again, and so trying to figure out how do you make that a smoother process, because from a money coming in, money going out, that's a lot of the expense then is the onboarding, recruiting, and churn. That's the more tactical part of it. The bigger picture is, I think this is different than what we're typically seeing when we're saying, okay, what's our profit margin, what's going to be our exit? And I think that if we think of it in more general terms, right? So a good idea that's self-sustaining, creates value, captures the value, and distributes the value to the participants that you need to keep engaging. So I think in this, you're clearly creating value. And I think figuring out how you capture that value in a way that resonates with the different participants, whether that's the government agency that you're looking for the funding, private industry that you're looking for funding for, so if I'm like Vituity, hypothetically speaking, right? So for Vituity, what would be in it for us to integrate you into our staffing model, right? And there would be positive publicity. It aligns with, we're a very mission-driven company. It aligns with our mission of improving lives. And so, you know, you want to figure out how do you make sure that what you're delivering and how you deliver resonates with the values of who you're appealing to, right? And which is, it seems really obvious when we're in our project because we're passionate about it, but you kind of have to put that aside and say, okay, for, you know, the health promoter in Kenya, right? If you're taking over their job by saying directly to the patient, maybe that's a place where, you know, kind of what you were saying, you need to be able to pivot and meet their needs so that they keep pushing this and kind of navigating that for each local ecosystem and then each partner.
Absolutely. Well, I'm hoping, you know, this community is here as a resource, so please give me your ideas, help me. I'm open to help.
Do you run your own, yes, do you run your own platform for the telehealth, or do you use a third-party platform?
We use a third party.
Which one is it?
VC.
Oh, I see, okay.
We're not bonded to VC
Okay.
forever. VC happened to believe in us at a very early stage and said, yes, you can use our platform.
Okay.
So I would say we're platform agnostic.
Okay.
But we have an early collaborator that believes in us and lets us use their platform.
And the only reason I'm asking is, and I have no affiliation, but Good Sam is a platform I use for EHS or emergency medical services oversight where I work locally, and it's just super easy and just basically requires any smartphone. So
Yeah.
from a scalability perspective, it uses existing resources, but like you said, any platform that
Right.
makes sense would be feasible. So,
I think
And
the
that's why we
advantage-
talked about a suite, right? So we
Yeah.
can say, hey, look, we have a suite of things, right? Do you need an EMR or do you have an EMR? Do you have a platform or do you need a platform? And then we bring in what you need.
Yeah.
And that it's getting in the weeds. VC is actually probably a pretty good choice for it
Okay.
because they're the lowest bandwidth
Yes.
for transmission. They're the ones who do like the
Yes.
shuttle,
oh yeah, okay.
to be able to get
Yes.
the shuttle with low bandwidth requirements. And Milton's pretty easy to work with.
Milton's awesome.
Perfect. Thank you, judges, for the feedback.
Thank you.
And congratulations, Tim. Thank you.
Thank you.
But as a physician.
take it away.
Thank you. Yeah, I'm Anthony Catalano. This is Max Helmetag and Vince Show, and we're excited to share with you Risk Benefit, a product to help physicians like me share important health information with patients and their families. I'm an emergency medicine physician, and I frequently enter into the lives of patients when they're at their most vulnerable. They're overwhelmed, they're scared. We created Risk Benefit as a tool for physicians like me to use to quickly access up-to-date information about the risks and benefits of various procedures and share this with patients and their families in an easily digestible way. So let's go over, a difficult patient encounter. Mrs. Smith, I'm sorry to tell you that your mother passed out today because she has a large clot that's blocking blood flow in her lungs. Now, we can start her on a blood thinner to help start treating this blood clot, but I also have this powerful clot-busting medication we can give her that might help her get better sooner and might even decrease her chance of potentially dying from this blood clot. But it can also increase the chance of serious bleeding, including bleeding in her brain. Now, we have to start one of these two therapies, and we only have a few minutes to decide. I mean, how do patients even begin to make these choices? And for that matter, how do physicians look up the information to share this with patients? Well, now they can go to Risk Benefit. So Risk Benefit solves two important problems. First off, there's no centralized searchable database for physicians to use to find up-to-date information about the risks and benefits of various procedures and interventions. Second, patients feel overwhelmed by medical jargon, yet they still ask for more information, but they want that information in ways that is easy for them to understand. So we created the Risk Benefit to solve that problem. Where do patients go currently to find this kind of information that they want? They go to Google, social media, WebMD, ChatGPT. Sometimes they're taken to advertisers' websites or even predatory products. For physicians, where do we currently go to get this information to share with patients? We go to PubMed and we have to sift through papers for 45 minutes to find the answers to questions. And even if we could find this information quickly, how do we share it with patients? Risk Benefit solves these two problems, and in doing so, it's a boon for hospital administrators too, who are interested in increasing patient satisfaction. Happy patients come back to the hospital for further care, and informed patients are less likely to litigate. So this is what we created. It's a central searchable database that physicians can subscribe to. All they have to do is log in, and once they're logged in, they can search for whatever intervention they're interested in, open it, and share it with the patient. They can bring this to the bedside. This is all based on previously published data, but a physician can customize this if they need to. They can walk into a patient room, decide they're a little higher risk, and they can make their own custom charts based on these previously made ones. So we thought we'd solve the problem. We made 600 of these intervention sheets based on various procedures and interventions that we do. We created a single Facebook and LinkedIn post, and we had over 160 pilot users in America, Canada, New Zealand, and Australia sign up to use this product. And in general, they loved it. They loved using it. But the one barrier they saw to using this in their daily patient activities was the fact that in some cases it kind of doubled their workload because they were already obligated to use their individual institutions' consent forms. So we were a little bummed out about that. We had this program that we loved, that patients loved, that physicians loved, but we were kind of thwarted because we needed to get institutional buy-in for this to really get used, to make this from a I don't know, nice to have product to a need to have product. This is what a standardized consent form looks like in some of the biggest, most prestigious hospitals in America. It's a simple fill-in-the-blank form that a patient's asked to sign at the end. It fulfills a legal requirement for consent, but it's really not patient-centered, nor is it informative. And so when providers have to spend a bunch of time looking these up, filling these out, they're really disincentivized to use a product like Risk Benefit. It's just giving them more work to do. It takes time from staff to complete. So this is just an occasional tool, not an essential one that they use. They can't use it with every single patient encounter. But really, our end users are our patients, and our patients consistently rank the decision-making process as scary and overwhelming. Studies have shown that using visual decision aids help increase patient satisfaction, comprehension, and involvement in the decision-making process. But what is consent? I mean, this is a really difficult concept. We like to use it as physicians as a verb. Did you consent that patient? This is unfortunate because it really does kind of boil this down to a legal requirement rather than an ethical one, where we leave out the informed part, the most important part of consent. And there's not really a standardized way of doing this either. It really boils down to the physician and the patient talking for a few minutes in the room before they're asked to sign a piece of paper. This is our competitor in the space. There's a couple of them out there that have procedure-specific consent forms. iMed Consent. So this costs $15 to $50 per provider per month to subscribe to. Now you can imagine if you were a patient and you were handed 8 to 10 pages of this dense jargon, it's a little difficult to understand. But then you're asked to sign at the end that says, yes, you were indeed informed of all of the risks and all of the benefits and potential alternatives of this procedure. You know, it's not really patient-centered, but it does make the lawyers happy, and I think we can do a whole lot better than this. So the solution, thank you to the HACT team. We've learned and innovated through a lot of the design series programs you guys put on. So we learned about product market fit. We already have this great resource that helps patients make data-driven choices using simplified graphics and language. But now by incorporating this into the informed consent process, it replaces the cumbersome, overwhelming legal documents that we've used before. And for physicians that use the risk-benefit consent forms, they can now show that the patient was indeed informed and consented. We've also been able to start a single sign-on for both Epic and Cerner, so providers can log in immediately and get access to the website. And we are working on capturing virtual signatures to upload so we don't have to waste paper with every single one of these. So now this is what they get. Rather than just the single graphics and evidence-based statistics with the publication citation, we now also have patient-friendly legal language that's incorporated that includes things like consent for a blood transfusion if needed. So 4 pages. The consent forms can be customized as well. So if you are logging in via single sign-on via Cerner or Epic, we can pull the information from the querying institution. We can customize this to put in the physician name, the institution name, and I think most importantly, while we have our standardized, easy to understand legal forms, for every institution that has their own forms committee and has to go through the rigmarole of deciding what they want to show patients, we can customize it with that as this pulls up. So you tell me what you'd like to receive if your mom ever shows up in the emergency department and needs to go to the OR at 2 o'clock in the morning. I'm going to take the risk benefit. We're almost ready to go to market. So our initial target population is obviously going to be emergency medicine providers. We already have a complete database emergency department, and we've had them professionally translated into Spanish. So that is a solve of those, printed, transcribed, scanned, uploaded legacy forms that people are traditionally using for formal consent today. Save our clerks and nurses time. And then papers that typically get lost and you can accidentally lose protected health information at the time, we can do away with those. Also, these forms can be populated with information for a single-use PDF without having to store any PHI, so risk benefit doesn't actually need to pull any patient health information at all to be able to complete these forms. All right, you saw the competition. I think we can do it better, and I think we can do it cheaper. So this is the subscription model we're looking at. By incorporating the informed consent forms into the risk benefit patient education tool, we turn this into a need to have rather than just a nice to have product. There's about 1 million physicians in the US, and initially if we can capture 10% of that market at a really low introductory price of less than $1 per month, that's already $1 million in revenue annually. We would love to grow this product, and I think it's pretty simple to get to the point where we can capture 30% of the US market. And if we can do $12 a month for a subscription, remembering that people are already paying $15 to $50 for a competitor, that's already $45 million a year in revenue. So let's talk about the future of RiskBen. So we can't wait to be able to have section editors that we can pay to update the database. So right now we have 600 procedures included, including many of the common procedures that we use in other specialties. But we'd like to grow it from 600 to over 4,000 procedures to really have a comprehensive database that can serve the entire house of medicine. We'd like to move these translations into more languages for global application. We'd love to have a single-click toggle, so you can toggle the graph type if the patient will learn better with a bar graph or stick figures. We'd love to have those there available too. Eventually, we want to move away from just a patient consent and a consent tool for procedures and interventions, but maybe for general pathology as well, and upload simple videos on a browser that they can watch as well. ultimately, I think we're very well positioned to benefit from the AI revolution. We would really like to expand from a data sharing platform to a data gathering platform. So if we can integrate with EHRs and insurance billing, we can actively obtain that real-time data of patient outcomes, and we can put it into a constantly updating model powered by machine learning, so we can really see real-time outcomes from patients and be kind of the biggest resource for what these are in the world. So that's it. We're trying to make a product that improves the way patients can make decisions about their own healthcare. Thank you very much.
Thank you for the great presentation, and we'll go ahead and have some time for questions from the judges.
Thanks. So clearly a problem. And I think one of the questions that I have is, we've tried different things to improve informed consent. Like, do you remember all the videos that you would show, like, I guess, like 10 years ago? I remember even like the VHS. Remember those? Like, you had the VCR with the TV, and you'd show it to the patient to show the procedure you're going to do. And then that got onto the computer, and you'd show them like a little MP3. And outside of like really pushing it, getting staff to adopt that and get that into the workflow was like a non-starter, even though it seems like it would be great for the patients, and the patients, they still have uncertainty, which is what they're really trying to get rid of, right? How do you envision, as you were talking about making this more interactive and more engaging, how do you envision keeping that buried within the informed consent process? Because I think that, to me, that's actually the key to your product, is by having it buried in the informed consent process, you buried it into a legally mandated part of the workflow so that it will actually get traction.
Correct. So you have to have patients sign that piece of paper somewhere, or hopefully sign the electronic scratch pad. So if they're getting us information, whether you pull it up on an iPad with them in the room, or you're printing out these 4 forms or however many forms an institution is going to require, you're already having a conversation about informed consent. You can point and say, look, there's even with surgery, there's a 50% chance you're going to die from this abdominal aortic aneurysm. This is a very serious surgery. And you can point to these visual graphics because you're already having that conversation and they already need to sign it. So you're just incorporating that at one time to bring in with the patient. You can also bring it in ahead of time so they can read up on whatever they need, and you can come back later. But this is hopefully not duplicating work by incorporating it into the consent process.
And then the second question has to do with long-term maintenance and cost structure, which is, at least in our experience, you create something and it was like a Herculean effort, and then you do like high fives because you're finally done with it, and then you find that you actually have to maintain it. And so we're mitigating or defraying that cost by partnering, or are you going to become content experts?
What was the last part?
Are you going to become the content experts?
Oh, I think we need to hire section editors from specific teams that are going to constantly update this database for those. So you pay someone a couple fellows or people who are very motivated to get their name as an editor of something, and they're going to be the ones that are going through the literature, updating any needs. Getting the initial database built, I think, is going to be the biggest effort. And then after that, you're updating it, right, as new literature comes out. So I can't do it by myself. We need a whole team of 50 physicians that are providing specialty care from every specialty in the House of Medicine to do this.
So a great presentation. I was just thinking about a few ideas as we were going through there. So you're almost ready to go to market. You have 600 procedures in the database, which certainly is a great launching point. You're probably covering the top 10% of procedures quite effectively with that database. Saves time, language translation, all that kind of stuff. Subscription model at a tolerable price point to get engaged in that long term makes sense. And just thinking about how you can scale it out. I mean, EMS systems, discharge planning from hospital. It's not just procedural consent, but I can see how you can discharge planning is a classic one. Just sending people home from hospital, inpatient wards. You've got pharmacies that are prescribing, and the pharmacies are dispensing medications. Having that spiel, you can centralize that, provide it. So I can see how this idea can be scaled out beyond that, the cap of the physician population. So I thought it was pretty interesting. And the profitability piece really is ultimately dependent on your ability to scale. But if you consider pharmaceutical companies are very motivated for their products to be visible to patients, and if their products are truly the products you're using in practice, I can see how maybe they would potentially sponsor some of the onboarding as long as you're able to, establish some boundaries. I would expect they'd likely want this presentation to be nice. So just a couple of ideas to think about.
And on that topic, it's completely outside of my area of expertise, certainly, but veterinary medicine and dentistry, right? Have you ever had to take your pet into the veterinarian? It's a huge area where I would love to see the risks and true benefits of what I'm doing for my pets.
Great presentation. I think you identified the problem very well. I think it resonates with a lot. I think my big question is your subscription model. It sounds like, for someone that doesn't have consent forms, anything established right now, it's a great way to get these forms. Now, moving forward, as we have language models, LLMs coming out, what's preventing a hospital from generating their own content and making it internally, moving forward? Because it looks like a hospital of 1,000 physicians, $10,000 a year, or is it $10 per month? Was it?
It would be a monthly subscription fee. Yeah.
So, it's a significant cost to a hospital, and you could argue someone could generate that content internally. So, what would be the value to the hospital that will support continuing that subscription?
The hardest part of this whole process is finding good data, right? Nobody's studying the risks of appendicitis anymore when you're doing an appendectomy. And so trying to scour the literature to find good data to use this, I think is the most difficult part, and really difficult for a language model to do as well. And so you have to have that core of physicians who's pulling good data. So this is not just coming from a computer, but someone who's looking through and saying, this is good quality data, this is good outcome, and so we're going to use this study. And so finding the studies is the hardest part.
Okay. Yeah, then my question was, because it's become, it's going to get easier to find that data with LLMs, and that would be my concern. It's already moving in that direction, so. Okay.
We might be able to take advantage of that too, right? So we want to move forward with that, but I think the oversight is the most important part.
Yeah, great presentation and important topic to tackle, and I really like your logo, by the way. My big concern comes from kind of the framing would be having conversations with Canadian physicians. Kevin, you're Canadian, right?
Yep.
Who, like, when they pitch good ideas about improving healthcare in the United States, and then we go down everything you were going to learn about the U.S. healthcare system is going to shock you into saying it can't be this bad, and then you realize it's that bad, and then it can't be this bad, and then you realize it's that bad, and then you keep going through these cycles. My concern with this is that you're competing against free, right? So you said your competition is IMED consent. I'd also consider UpToDate, MD Calc, the NNT. All those folks are somewhat competitive, but really your competitor is that piece of paper that's like a copy of a copy of a copy that the unit secretary is trying to figure out how to not cut off half of the paper. And for a hospital administrator, that is the perfect solution, right? There is no problem to be solved here. And so how do you get around the competing for free against free problem?
It's a hard round, but I think that is in informed patients, right? It's the patient satisfaction. If you went to a hospital and they gave you something like this for your appendectomy, and the next time you had to go in to get your gallbladder taken out, and they give you some piece of paper where somebody scribbled on some form they can't even read, which hospital are you going to go to do the third time? So moving forward, I think the more informed patients are more satisfied patients, and so they're going to go to places that have a better resource like this.
Wonderful. Thank you so much. All right, so we will take
Everybody, we are back. Welcome to HAPS Day 3. This is our pitch competition. So again, these teams have been iterating on their ideas for the past 48 hours here at Scientific Assembly. We've got a fantastic third team to present here. We'll have 4 teams total. Thank you to our wonderful judges for being here. And we'll kick it off. They'll have 10 minutes to present, followed by questions and answers from the judges. I'll let them take it away.
Just real quickly, does this advance or just this?
Just that.
Okay. Hello? Yes? Hello? All right. Hi. Just want to say thanks to ASAP and this whole event. It's been very informative and helped to stir up lots of ideas. Today we want to talk to you about Native RX. I'm Dr. Shaniqua McLeod, and this is Kulichi Umoga, who's in his last year of residency? Third year of residency. Okay. Lots of problems in healthcare. We're here to find solutions. Today, the problem we want to talk about is discharging patients and the cost associated with it. According to the CDC, there's about 140 million visits in the ED a year, and that can get pretty pricey. Nothing?
So it's coming in.
What?
I think there's a lot.
So that's advancing, but the computer's. So $32 billion of avoidable ED visits. There's lots of people who need to see us. We have the best turkey sandwiches. They got to come in for those. Other visits are avoidable, and there's a bunch of reasons for this. Top one is the health literacy of our patients. Only 12% of people have health literacy. What does that mean? Only 12% can make actual informed decisions about their care, the care of their family members. The other ones are just kind of winging it, depending on Dr. Google and WebMD. You see increased utilization in the emergency department from these patients because of their lack of health literacy. You saw a patient, you thought you were pretty clear on what's going on. They didn't agree, but they also didn't tell you. So now you're discharging them. What do these things lead to? You have increased resource utilization, and you have people who aren't following up. They're not going to the appointment that you made for them. They're not taking the prescriptions that you sent for them, and they just come back. They come back mostly sicker than when they left. And that's where we want to help.
So our solution is native RX. So native, like a native language, native what you're comfortable with. So it's an audio solution to complex patient discharge instructions. And the idea is, is based upon the assumption that patients oftentimes leave the emergency department not knowing what they're going to do. You tell them things, they forget it. You tell them things, you send them, you give them paperwork, they can't even read it or understand what you've told them. So here's our solution to that problem. So how does it work? So take for example, a patient comes in, dressed like I'm dressed, a little unusual, with an unusual name. You're thinking, oh my God, you're not English speaking, you're reaching for an interpreter, you're doing all the things. They come here, you're done with your discharge, you're done with your evaluation and send the discharge down. Oh, sorry, I think I moved it. The provider provides paperwork, like discharge instructions. They dictate what the follow-up precautions are. It's given to the patient. The patient scans. So we include that write-up into a platform, our digital platform. It converts it to a QR code that the patient can actually scan. The patient scans the QR code, and there's an audio readback in the patient's native language to the patient what they need to come back for. They can go back to it multiple times. And we hope that in the future, we can actually iterate where they can actually interact with the instructions and ask follow-up questions. So, based on studies, audio discharge instructions have been shown to increase patient comprehension, prevent hospital readmissions, and also improve overall quality of care. So our audio feature, again, is unique in that current discharge instructions are limited to text, And we are trying to like improve upon that and make it more audio that they can actually hear. So a patient who is visually impaired or basically cannot understand English can have something that they're familiar with. We're also hoping to implement AI in this process where the patient can actually interact with those instructions and ask follow-up questions as needed. Finally, we're offering diverse languages, languages above and beyond the regular languages that you have in-person interpreters for. So this is our total addressable market. And the serviceable available market is 20 billion, and then the serviceable obtainable market is 3 billion. So honing in a little bit on our customer. So our customer essentially are emergency departments and healthcare systems. Approximately there are 5,000 EDs in the US, about 140 million visits per year, and 42% are seen in less than 10 minutes. The big barriers are like the difficulty accessing in-person interpreters. I know how much of a hassle it is getting them there to like see the patient both upon initial evaluation and at discharge. Literacy barriers, high patient volume, boarding, and medically vulnerable populations. So as mentioned, our target audience are emergency departments. We're going to have like a tiered subscription model. They can subscribe to however much they want from us. And eventually the end users are patients. So we're hoping that Native RX will be marketed to US-based emergency departments through like a B2B and to C model. Just like a brief overview of potential price and modeling. So we're going to have it tiered between like small hospitals, large hospitals, medium hospitals, depending on their volume. They're going to have an initial setup fee, and they're going to have like an annual subscription fee based on whatever support we're offering through our intervention. So special thanks to our mentors, Dr. Onyeka, Dr. Buchanan, and Nicole Thomas. They've helped both with the ideation with us and also in helping develop what we have as like a minimal viable product right now. Thank you, and I have an appendix. We can go through a quick demo, if that's okay with you guys, just so we can see how this works practically. All right, so this, for example, this platform here, I said you're done seeing a patient, you type your discharge instructions, your follow-up appointment is on Tuesday, March, whatever, take your antibiotics. You type that, and the doctor generates a QR code. So if you guys can actually scan this QR code and see how it works. So the default language is Spanish. That's all we have right now. You can listen to those instructions in Spanish. Success? All right, so in a nutshell, that's exactly how it works. The doctor sees the patient, taps discharge instructions, generates the QR code. The QR code is included in the paperwork. The patient, all the patient has to do is scan the QR code, and he hears the discharge instructions in his language. Again, in the future, we're hoping to build on this, where they can actually interact with it, ask follow-up questions, and go back to listen.
Some other benefits of the code are that they can forward it to someone else if they don't understand. They can forward it to, what did they mean, like I'm supposed to go to this clinic, or every 12 hours do I have to wake up in the middle of the night? So you can put in however specific instructions that you need, and they can send that to someone else and revisit it as needed.
And go back to the slide. Okay, I think that's all we have. Thank you.
Fantastic job. So once again, we'll pass it over to our judges to give some thoughts, feedback, questions, and we'll let them take it away.
First of all, the presentation was great, and the slides, you guys crushed it with the slides. I feel like we have to like hire you guys as like designers. Like slides were great. So I do have a few thoughts and then some questions. I guess from the order of the presentation, I didn't quite buy the ED visit, unnecessary ED visits as the right outcome, right? You're providing a really cool service to patients and providers that these days is quite low cost and can really provide improved care on discharge. I'm not sure that you need to also solve world hunger, right? You don't need to prevent ED discharges. You don't need to solve $32 billion of something. You're doing something really cheap, really easy with LLMs that can provide huge value in itself. So I would just pitch what you're doing. Like, you don't need to be something else. You're doing great. And then one of the, like, and Josh can speak to this potentially more than I can. The way to raise money these days in health tech and early stage venture is to fill in the blank AI for, and then just put in a word, right? And so if you start with, our company is AI for discharge instructions, right? How many discharges are there from emergency departments, urgent cares, real quick, keep on going. The end there is just gargantuan. And so if you have a low cost, high volume solution that has a sexy title and using sexy technology, the business really, I think you can get like legit funding just because it's it's potentially a very big business using cool new technology. One other piece of the puzzle is that this is because AI is crowded, it's moving fast, everybody's scrambling for AI for fill in the blank. I think one thing that you would need if you're gonna raise money is a go-to-market strategy, right? So like, since anybody can use an LLM and get audio of text, why is sorry if I'm gonna mispronounce the name. Native RX. Why is Native RX gonna beat all the other AI companies? And so I think a good go-to-market strategy would be really important. I'm not sure I got to a question there.
That's okay.
So I guess, feel free to take any of those things and
Take all of them.
Yeah.
Yeah, I agree with Lamont. I mean, that's a great presentation. You really hit all the important questions any investor would want in a slide. So I commend you on that. That's great. I also have a similar question regarding, if you're looking at your competitive comparison, what is it that differentiates you from these established competitors who've been in this game for 20 plus years creating discharge summaries? I mean, it's pretty well written discharge summaries, and I understand that you're adding like accessibility, an element to that for anybody that has visual impairment or they can't understand language. That's a great differentiator. But is there anything beyond accessibility that is going to make a hospital choose you over the established company? So that's my one question. And the other is from a provider standpoint, what's your strategy for workflow for using these discharge instructions? Like, how am I in my EMR going to launch another app so that I can create discharge instructions, or is this going to be integrated into my discharge workflow? I guess that could be another barrier for provider adoption.
Yeah, excellent question. So I'll start with the first. Right now, I mean, you're absolutely right. This Google Voice or Google Audio, some people experiment with typing out discharge instructions in English and putting it in Google Translate, and there's studies after studies showing that these are not as accurate as what we're going for. The beautiful thing about this is it's specific so it's actually written by the physician. These are not preformed text on, like a biliary colic or just random chief complaints. Specific instructions provided by the physician that is taken verbatim in using AI to like produce like an audio output. So it's not like your Google Translate mechanism. The second response I get to, I guess your second question, there's two ways you can go about this. We can integrate this into the EMR. So once you hit that display button, it takes you to like our software, like a launching pad, where you type in your instructions and then you go. Or it could just, everything could be within Epic or whatever EMR you have. We don't even have to leave. That launching pad stays within Epic. That way, you know, if there's internet issues, you're not scrambling. So that's what we're thinking. So it could be an external adjunct where it takes you to a different landing page or just within the EMR. So we try to experiment with it. We're actually piloting this in like a few community centers. We'll think about that in the medium term and just see how it goes for workflow. We'll iterate as needed.
Just a question about the compensation model. So was it like $500,000 a year subscription model for hospitals? Is that sort of what the model was? Or can you describe how are you getting, what was the model for getting paid?
Yeah, so again, these are just rough estimates, but the big picture is there'll be a flat rate just to get the service. And then depending on how much you want, you can subscribe annually. So there's a flat rate just to like purchase the service and then like a subscription model. That's what I'm thinking. In terms of actual figures, we'll see, we have to work that out in terms of like how much exactly we're going to charge this hospital system. Obviously, it's based on development fee and all that.
What was the number of the presentation? I think it was a large number, if I'm not mistaken.
Yes.
Sorry.
Yes, so I think we're thinking this will be packaged based on like how big the hospital is, and then the first and the second column, that will be the flat rate fee, and then followed by like annual subscriptions.
Right, so just the feedback, I think,
Yes.
like those numbers are pretty large. I suspect you're gonna run into some barriers presenting that model, but, you know, flip the script a little bit. You know, if there's 150 million discharges from the ED every year, if you said, for example, it's $1 a discharge, you're saving $20 of communication time from that healthcare professional. By streamlining this, you can layer packets of pre-generated content quickly on your discharge, like the fever checkbox and the whatever post-op pain checkbox. Just layer those on quickly. Your AI algorithm can mine that data to answer the patient's questions reliably within the information provided. It seems to me, if I'm discharging a patient, I'm like, click, listen to this, ask any questions in your language. I'll come back in 5 minutes, check in with you. You're good to go. Great. Take this home with you, all your family members. That was $1. You know, for the discharge, there's 150 million discharges a year. You can, whether it's $1 or $2, whatever. I feel that anybody can pay for the price of a cup of coffee on a daily basis. But trying to present those numbers is likely going to be challenging. So just a different way of thinking about it.
So you're understanding correctly. So this would be at the level of the patient being charged.
Well, somebody would be charged something, but I think that it's unlikely someone's going to upfront those costs.
Gotcha.
But it wouldn't be difficult to say it's pay to play. I mean, if it's $5 for 5 patients, is $5 million for 5 million patient discharges. It's scalable where the value is with each interaction, and the ROI on each interaction pays for itself. Would be a way you can consider building the model.
Absolutely, thank you.
Yeah, so I'm sorry, I had to step out, I had a family emergency. But I think, so I really like the idea. I think probably my concern, but I think an opportunity is to realign this whole, and I'm a very basic person. So going back to value creation, value capture, value distribution. And I think creating value in patient experience is incredibly challenging because no one actually pays for patient experience. They pay to prevent leakage, right? They want the patient to return to them. And I think you actually, when you say we can avoid unnecessary emergency departments, well, that's like, we're ERs, we're car dealerships, right? Like, so you come in, I want to sell you a car. So I don't want to avoid an unnecessary emergency department. Your payer wants you to avoid that unnecessary emergency department. But you're going to be giving this to the hospital, not the payer. So you want your value proposition to align with what your user and purchaser wants to do. And I actually think you could probably tweak this to do that really well. What I would suggest is you think about, could you have those discharge instructions help that patient know that they need a follow-up, whatever it is within that health system now, right? So I'm leaving the emergency department, I don't understand what my follow-up is, I'm likely going to get better anyway, but if instead I get these discharge instructions that can be anticipatory guidance and help guide me to this health system, Our Lady of the Worthless Miracle, I get guided to their radiology department. I get guided to their primary care office. I get guided within that system. Now you're short circuiting. We have this hypothesis that patient experience leads to better retention within the health system, which leads to higher margin business for outpatient radiology and such, right? But you can say that more important than that the patient was pleased was the patient knows what to do. And we make sure the patient knows where to go, and we make sure they know to go within your health system. And I think that's how you actually create value. Then you can actually capture that value by showing when patients use our system, they are more likely to show up in your radiology outpatient office, right? That a system knows the exact dollar figure they can put that on. And that's how I would expect you could actually capture that value and then distribute it back to yourself.
Amazing. Thank you. It's very helpful.
Just what I thought, you maybe think of it as you're talking. I mean, you could even potentially layer on a calendarizing function where it reminds you, it prompts you through your phone or whatever, your smartphone. Hey, how are you doing 2 days after this visit? Oh, interesting. You're showing symptoms. Why don't you come on back and see us? We'll automatically book you an appointment. There's different layers to keeping the engagement by having that discharge instruction as a point of contact that can continue beyond the discharge experience.
I think we all had a couple of comments. Josh did a great job, Josh and Kevin. It's just how you frame that value proposition. And I agree, actually, making it sound like you're saving time is actually, I think that's another key way to attract your clients. Is if you're saving that 5 minutes for that provider, it's not just like a wellness thing that I may not like to do something too much, but it's 5 minutes of my time scaled over my over the year. It's a significant amount of time saving, and there's money. There's value to that time saving, and I think you could actually calculate that and have that part of your value proposition. I think that makes it a stronger selling factor, than the other one that you mentioned there about the patient satisfaction, which is important, absolutely important. But from a payer, you have to address what they want.
And weirdly enough, in the age of LLMs, like becoming a discharge care navigation tool that is culturally integrated with the patient's life, and whether it's audio, whether it's language, whether it's using the right phrasing, and then getting patients to the right place, all of that is incredibly cheap. It's all incredibly cheap, right? And so I feel like, I guess my grand conclusion from all this discussion is AI for discharge instructions and post-discharge care navigation is a potentially phenomenal company that you guys need to run with.
Thank you.
That's it.
Congratulations. Thank you so much for your presentation. This is what it's all about, y'all. Getting this feedback in real time from folks in the field to continue to grow and evolve. That's the spirit of these hackathons. So thank you all for participating. Wonderful job. Again, we'll take a 5-minute pause before our next presentation. We'll be concluding with this last presentation here in 5 minutes. So please stick around.
How's your
All right, and then you've got your mic to the right is on. All right, everybody, welcome back to Hacked 2024. We are in the middle of our pitch competition right now. We'll be closing out with one final pitch. You've heard from 3 great ideas so far today. A big thank you to our panel of judges up here for taking time to give feedback and questions to our groups. So I'm going to pass it off to Christian for our final pitch today. Our singular engineer joining us at Hacked, and we're really glad to have him here. He's been working hard, and I think one of the really great things about Hacked is all of the pivoting that all these teams are doing. Christian was initially on a team with several people. The rest of his team was unable to make it, so he's been iterating on his own and working really closely with our coaches to get from concept to this pitch that you see today over the past 48 hours. So again, really proud of all of our teams for all of the iterating and ideation that they've done over the past 48 hours in particular, and taking all of these pearls we gain along the way to come up with some really interesting ideas. So without further ado, I will pass it off to Christian for our final pitch of the day.
Thank you, Nick. Hello, everybody. My name is Christian Pineda. I'm a software engineer with background in developing AI applications for contact centers. I came up with this idea when I was talking to one of the people that attended, the members of the other teams, and the basic idea is actually a triage that people can. I'm sorry. A self triage system powered by AI. So I created this mock-up showing what's possible, and basically we're gonna have a holographic display that will instruct people with 3D images how to use the attachments like the blood pressure monitor. We're gonna have a thermal camera to measure their temperature, and also measure their heartbeat. All of these is gonna be fed to an AI model that is gonna interact with them in real time. It's voice AI. So the current emergency department triage. So I took the time to talk to a lot of physicians here, and what I keep hearing from them is that there's normally a lot of wait times in the emergency departments for them to triage.
What one do you want?
And a lot of times they're understaffed. There are inefficient evaluations. And each patient has very different approach. I mean, for each patient, the approach to evaluate them is very different. So the target population for this system would be emergency departments, urgent care centers, primary care facilities, telemedicine and virtual health centers, walk-in clinics, and retail health clinics. And there's also potential for others like schools, universities, and nursing homes. Okay, so the whole purpose of this solution is to transform the experience patients have when they come to the emergency department, and have them be triaged as soon as possible. And it's going to be an interactive engagement with a machine. It's going to be talking to them. One of the advantages is multilingual system, so they will be able to choose what language they speak, and the machine will speak their language. Um, based on what the patient is telling them, the system will analyze the data and send it to the doctors, um, with labels, summarization of the vitals and next step recommendations. Um, to implement these, ideally it would be implemented in emergency rooms where there's constant monitoring that the system is not failing or the AI is not having hallucinations. Um, and then it will be phased out to other healthcare providers. The technical feasibility, we're basically not inventing anything new. We're just merging technologies like holographic displays, AI, language models, speech recognition, speech synthesis, and some of the challenges I see common is HIPAA compliance, handling data privacy and cybersecurity concerns, which will all be addressed. This is something that has been put together in 48 hours, so I'm pretty sure there's a lot more that can be done to address compliance and privacy concerns. So the business model will be selling these units to hospitals and clinics, and then we're gonna have a subscription model, which will cover for the cost of operating things like inferencing and speech recognition, data storage, all this stuff. Well, yeah, I want to talk about the savings that it can, the cost savings for hospitals. It it can save them a lot of labor or people to be triaging by just automating that phase stage when somebody walks into the ER and gets immediately seen by one of these machines and get prioritized based on their symptoms. Well, I think that's it for me. Any questions?
Did you want to show your demo?
Oh, sure. Okay, so this demo, it's gonna be the user interface where they choose the language they speak, and then they just hit call to start the conversation with the machine. They will be sitting on the kiosk, so the machine will already know their vitals and use it as part of the whole assessment process. Okay, I think I'm gonna be back here because I'm using my computer's microphone.
Hi, Christian. Thank you for using our automated triage. This is Linda, your AI assistant. I will ask you a few questions to determine the emergency and let the physician know you are ready to be seen. Please tell me your symptoms and I will guide you through the process.
Hi, I'm having chest pain.
I'm sorry to hear that. Can you describe the pain? Is it sharp, dull, or a pressure-like sensation?
It's a sharp pain, and it's just constantly there.
Thank you for sharing that. How long have you been experiencing this chest pain?
For the last 2 hours.
I understand. Is the pain localized to one spot, or does it radiate to other parts of your body, such as your arm, neck, jaw, or back?
Oh, can you repeat that?
Of course. Is the pain localized to one spot, or does it spread to other parts of your body, such as your arm, neck, jaw, or back?
Yes, it's radiating to my jaw.
Thank you for letting me know. Are you also experiencing any other symptoms, such as shortness of breath, sweating, nausea, or dizziness?
Okay, you guys get the idea. I have random voices every time you call it. It picks a different voice. It picked the lowest quality voice it could. Some of the voices are very realistic. That's the whole idea. Once the conversation finishes, it analyzes it, breaks it down for the doctor, and brings it up on a triage system where a nurse or anybody can assign a term for it, or just see what it is all about, and they'll get the transcripts so they can take it from there.
Thanks, Christian. I'll pass it off to the judges.
Thanks. Did you vote the demo then? Yeah. All right. Very nicely done. Thanks. So I think, at least from my perspective, the actual AI part of the intake process and using AI to have that conversation with the patient. I know we have a company that we've worked with the past few years to make that happen. And there are just an incredible amount of complications that we run into with patients and how they communicate, and then what AI models actually work, because you can use knowledge graphs, and then you have latency problems with conversations, and there's too much abandonment, and so we had to do like all these tricks to make it feel like it's faster. So I would try to think, I think the use case that you have of doing the triage intake, I think is a challenging one, both from most departments don't have that a problem. Obviously, less resource departments do, and so there's actually a smaller market than I think the perception is for that. That being said, that demo was pretty impressive, and so I think there are probably other use cases involving patient engagement and patient interaction that you could pursue. Really interesting. Thank you.
Yes, I was thinking about traveling through the airports, you go through the security lineups where you've got the Nexus lineup, which is a bunch of kiosks that are very efficient. So that's multiplied by an array of, we call it 20 kiosks, versus the bottleneck of the wait line to get to the few agents, the border agents to get interrogated that way. And so the analogy of the emergency department, of course, is that when it's busy, it's really busy, and the bottleneck is triage. And so by multiplying that out, I can certainly see, from an ROI on resource utilization and the ability to the goal of triage to assess what the complaint is and how significant it is, and then apply a lens against that. The idea of the model, it makes a lot of sense. Almost certainly, this will be happening at some point in time in the next 10 or 20 years, where these models are part of triage and all kinds of patient assessments and all kinds of other things to improve workflow and everything else. And I also echo the press to build that in 48 hours and have it work. So that's kind of cool.
Good job. And then in 48-hour constraint, this is to talk to the presentation together. I think the key would be, moving forward with the presentation, iterating and practicing is huge to make sure that it flows and captivate your audience. Good job at 48-hour constraint. I think the concern would be from a scalability standpoint, having hardware in kiosks makes it harder to deploy this. So I would think of ways to reduce hardware requirements. The cost of med tech to do vitals in an ER is much cheaper and scalable than a kiosk hardware costs. One kiosk that a hospital has to buy. But the value really isn't in the hardware. It's not in getting the vitals, because that's the cheap part and the quick part. It's the interaction with the patient, the conversation is the longer piece, and how we capitalize on that as your selling point. I'm not sure if I see the value in the hardware kiosk other than a privacy container, so that there's HIPAA concerns.
No, it makes sense. You mind if I add something to that? So the initial idea was to have a QR code people scan, and then they can just call and get triage on the phone. But after working on the floor, talking to some physicians, a lot of them mentioned it would be great if you can also take their vitals. So, I created that mock-up for the whole weeks. I called it to satisfy their needs. I mean, their upper needs. Maybe I didn't tell too much of them.
Yeah, I think your technological skills and the market are both spot on. Like what you created is really impressive. You're in a big market that has a lot of need. I think what my advice would be is to hone in on your customer discovery. You've got this big market, a lot of money in this market, and the question is like, what do you, as an individual, like, how do you attack this, right? And are you going to attack this inside of a company that's already doing some of this stuff, and then use your skill set to build a product with them for them? Or is there something like totally missing that over and over potential customers that you talk about are like, there's this glaring piece of the market that even big companies aren't even trying to solve, and nobody's willing to do it, so I'm going to just do it on my own. My guess of what you're going to find is that this is a crowded market, but it is not crowded with people with your skill set, right? And so using your skill set within an organization that's already working on this, it might end up being a wiser move.
Thank you. Perfect. All right, thank you, judges, and thank you, Christian, for your presentation.
Thanks, Nick.
All right, everybody, that wraps up CAPS 2024 as far as the pitch competition goes. So what's going to happen now is our judges are going to deliberate, and we will come back to announce the winners here in this space at 3 p.m. So please join us back here. We've got a little bit of time
To grab some lunch, check out the exhibit hall. I do encourage you to come back at 2:45. What's happening then is our winner from last year, the company EXG, is going to be giving a presentation to talk about their experience and the progress they've made over the past year, in large part inspired by their experience at Hacked. So again, we hope to see you back here at 2:45 for that talk. At 3 p.m. today, we'll announce the winner. And a big thank you to our judges and to y'all for being here.